every first letter holds a meaning. Now, let us understand this meaning, light. Now, this light is different from your white light. Your laser light is different from white light. Why? Because number one, it's monochromatic. Why is it monochromatic? Because it is released from single element. Number two, it's coherent, which means all the photons that are emitting from the optical resonator, they are in phase with each other. So they're identical in properties, which is called coherency. And third, it's collimated because they're released from very small some sort of exit points. So they are parallel beams. So they are not diverging. And that's exactly what we want when you're using the laser for therapeutic purposes. So this is a light. Coming on to the second word, your amplification by stimulated emission of radiation. Now, Albert Einstein in 1916 gave the concept of stimulated emission. Now, all of us relate to this word because we all know the concept of Neil-Bohr's atom, where you have an atom surrounded by electrons and orbitals. The electron gets excited, goes to the other orbital, and that's an unstable state. It comes back, releases an energy. This is called spontaneous emission. But if the electron goes to the higher orbital and has the capability of a good half-life and can sustain at a metastable state, and then if it is bombarded with a photon, it exits with two similar photons with similar energy, and that becomes a stimulated emission. And when all these stimulations are happening inside an optical resonator with two mirrors where both the photons are colliding, what comes out from the 99% reflective mirror is a super amplified bright light, which is called the laser light. Now, all these radiations comprises of electromagnetic spectrum. So if you see it on the screen, you have the left side, the center portion of the spectrum, and the right side. Now, the UV, or the 100 to 400 nanometer, which is called the UV spectrum, is actually highly energized and your ionizing radiations because the wavelengths are short. So it's a inverse proportionate, that if you have shorter wavelengths, they would carry more energy, and if you have longer wavelengths, they would carry less energy. It's very similar to you standing on a beach. I know it's been a long, any of us had a vacation, but if you all go back to your beach days and you think about those waves hitting your leg, you know that when you have a wave which is huge, it's a huge tide. So the effect on your foot is very gentle in comparison to the short waves that keeps on coming. So the energy they are carrying is more. It's similar science, you have to apply it here. So we hardly use the left side of the spectrum for your dental purposes or the periodontal tissues. Now we have the visible spectrum, which is for 400 to 700 nanometers. Of course, we know that we use it for your curing the composites, and your earlier lasers were helium neon and 500 and 600 nanometers. Now, they were excellent for your ablation and excisions, but because the absorption in water was not good, they had a lot of thermal collateral damage. So we hardly use it now. And now we have some diodes, which are 810, 940, 980. They're different generation diodes. 810 is the first generation diode, then you have a second generation, and the latest is the 940 nanometer. Now they differ in their absorption of water. And 810 nanometer, if any one of you has an 810 nanometer, you know that when you make an incision with an 810 nanometer, it leaves black charring. That's because the thermal coefficient is very high because there's no absorption in water. In comparison to 940 and 980, where the incisions can be a little bit more smoother because they have high absorptions in water. Then you have another soft tissue lasers like ND-YAG and CO2 lasers, which I wouldn't be discussing for the webinar. I would straight go to the erbium lasers, which are again lying in the infrared, but they're mid-infrared, 2780 and 2940 nanometers. Now, these are mid-infrared, and they are high wavelength, short energy, low penetration depth, and very high absorption in water. So we'll just understand in the next few slides what is the importance of having high absorption of an erbium laser, which is the topic for today. So based on the spectrum, we can classify the lasers into hard lasers and soft lasers. So one needs to know that the classification, when we often say about hard tissue laser and soft tissue laser, that's not the right way of doing the classification, because when we say soft lasers, we are talking about anything which is non-surgical and therapeutic, like a cold laser, photobiomodulation, photodynamic therapy, or the aiming beams. And when we are talking about hard lasers, we are talking about surgical lasers, which can further be classified into your hard tissue and soft tissue, and they can do various kind of purposes. So this is how the classification goes. And on the screen you can see some different kind of lasers available. You have diodes, you have 940 nanometer, and you have multi wavelength diodes. You also have some all tissue lasers, which is a truly all tissue laser 2780 YSEG laser, because it can work both on soft tissue and hard tissue. And then you have Nd:YAGs, which are very popular for your perio purposes, known as periolace. Now, how do you decide which laser you want to use? And I often am asked from my colleagues and my associates and my students that, ma'am, how do we decide that which laser we need to buy, and how do we define the unit of the laser? So, the best way to understand the mechanism of action of a laser is to understand this graph that you see on the screen. And the most important thing here is the chromophores. Now, what are the chromophores? Chromophores are pigments in the body that absorb the light. So they are specific pigments that illuminate and they absorb. So their absorption coefficient matches the light which is falling on them. For example, if you see the diodes 940, 980, 810. So if you see the graphs on the top of the melanin, protein, hemoglobin, and water, 810 nanometer has the lowest absorption in water, which means your soft tissues are nothing by 80% of water. So if it is not absorbing the water, it is all penetrating to the depth, and that is why when you use a 810 nanometer, you have a lot of thermal charring and a lot of heat buildup. Now, if you shift to 980 nanometer, I see that 980 nanometer has a high absorption in water, which is good, but then the absorption in the hemoglobin of a 982 is little less. So your hemostasis property is not that optimum. Now, when I compare both these wavelengths with 940 nanometer, it has an optimum absorption in water as well as hemoglobin, exactly what we want. So we need the absorption in hemoglobin for hemostasis, and we need the absorption in water for a faster ablation work. So that's 940. And if you come on the right side of the graph and you compare the tooth enamel, which is hydroxyapatite, and water, we see that 2780 YSDG laser has a absorption in water and hydroxyapatite, exactly what we want when we are cutting the tooth or cutting a bone, in comparison to YAG, which has a super high absorption in water, which makes the work in soft tissue really slow, and there's a lot of thermal accumulation because of the mechanism of action. And that is why with the YAG laser, we often give Nd:YAG attachments for the soft tissue work. Now, we discussed about the absorption of water in different wavelengths. And this is a very important fact to understand because this defines the depth of penetration. Now, a laser wavelength which has higher absorption in water would always have lower depth of penetration. Why? Because the entire water absorbs the energy, and there's nothing that goes scattering or at the lower levels of your tissues. But in comparison to something like 440, 660, 810, where you have no absorption in water, the entire waves, the energy or the laser, it goes to the bottom because it's all scattering and there's a lot of thermal collateral damage happening. So that is why when we talk about erbium laser, we say that the depth of penetration of a erbium laser, a water laser probably, or a YSDG laser is just 3 to 4 microns. And if you imagine 3 to 4 microns, we are talking about 10 to 20 cells. That is it. So if I compare that with different wavelengths and different diodes, so we know that diode would be 100 cells, a blade would be 300 cells, a cautery would be very destructive. It's 1 to 2 millimeters. So it just keeps on increasing the thermal zone of destructions. And the recent technology or the most advanced cutting edge laser that we have now is your YSEG laser with super superficial effect, and it's able to do all the purposes with just that minimal invasive action. So now look at the cases like a soft tissue which is covering the bracket or operculum at the third molar, class 2s having gingival polyps, crown lengthening with the inappropriate furrow, excessive of gingiva hypertrophy, a wire embedded in the palatal tissue, stage 2 of implants to recover the screws or the healing abutments, and gingivectomy and exposure of the caries. Now, these are all different situations which entails soft tissue work. It can be done with a 940 nanometer or any diode laser, and it can be done with the erbium laser. Of course, we will see the difference of doing both them in these situations. And then you have some periodontal patients like recessions, your lot of pocket depths, clinical attachment loss, depigmentation, lot of deeper suppurations, and bleeding on probing. So again, some of them can be dealt with your diode lasers, and definitely all of them can be dealt with your all tissue lasers. And then you have some implant infections like perimplantitis, stage 2s, graftings, increasing the biotype of the tissue around the implant and increasing the keratinized tissue, your socket grafting, your ramus block grafts, cleaning the extraction socket. Definitely all these cases I would do with the erbium lasers, because maybe you can use a photobiomodulatory effect with the diode to clean the socket, but it would be more of an erbium laser. And endodontic infections, which includes your focal areas, periapical, recurrent cases, ledges. You can use a diode laser for bactericidal effect, but an erbium would help to remove smear layer cavitation process and clean the entire irrigant. So, of course, I wouldn't be going into all these different spheres. I would be just restricting myself to the periodontal procedures. In post, we discuss each of every case that I showed on the screen in detail, but I will not be able to do that here right now. So, in brief, to conclude, what is a diode laser? A diode laser is number one, a semiconductor laser, okay, and it can work in a continuous mode and a gated. Continuous mode, you put on the switch and the continuous waves which are coming of the energy. And gated means that you have a physical gate in the machine. So when the laser wavelength is coming out, there's a gate restricting the energy and it's reduced to its intensity. So the advantage of using a gated mode is you have more time between the waves, so you have more of thermal relaxation, and a continuous would be faster, but there might be a lot of thermal buildup if you are beginners in your cases. So a soft tissue laser, number one, works on the soft tissue. It cannot work on any kind of hard tissue. The coagulative properties and the hemostasis is super fast and super nice. Why? Because these lasers have absorption in hemoglobin and minimal swelling and scarring, because these lasers have bystander biomodulatory effect that leads to sealing of the lymphatic vessels. There is no pain post-op because it cauterizes the nerve endings, and it has a very predictable tissue response, because unlike blades where you do an incision or do a crown lengthening, you have to wait for 3 to 4 weeks for the tissue to shrink or to swell, because you don't know where the gingival margins would be. But in a laser situation where you just remove your changes in the collagen, or at a molecular level, the changes are very predictable. So it's not going to shrink drastically, and you would be able to predict your margins just right on the same appointment and go ahead and make your impressions. Now, when we go into the erbium lasers, what lays, we need to understand that how erbium lasers are different in mechanism of action. So your diode lasers work on the phenomena of photothermal. Photo means light, which is laser. Thermal means heat. So when you put your laser on a tissue surface, your zones of different temperature appear. So it's, you have, the moment you touch the laser that has the highest, that's the closest to your laser, so that would have the highest temperature. That around that you would have a little bit lesser temperature, because the now the energy is diffused, and you would have a zone of coagulation, and you have then zone of denaturation, and then you zone up photobiomodulation. So you have different degrees, and this is called photothermal effect. And this is how a diode laser would work. Let us see a case where a diode is working, so you can appreciate the difference between a diode and an erbium laser. So that's a 400 micron tip that I'm using at 1 watt continuous mode, 940 nanometer. And you can see I have given a local anesthetic, because when we are going a little bit deep, trying to do a vestibuloplasty with the frenectomy, I like to give the anesthetics. And you can see the plumes. So I have a high vacuum suction to take away all the heat and the plumes. And you can see that I have a white margin around the wound. So what is this white margin? This is a zone of coagulation happening. So this is the volume of cut, where the center is your ablation and periphery is surrounded with your coagulation and the zone of edema. And beautiful work. You can see that we have accessibility, we have visibility, hemostasis. We are living in COVID era, so no infection here. It's all clean. But I do see some heat deposits. Now, why do I see those black brown chars as I go down? Because the collagen is white and the lasers are absorbed by colors. So the collagen has no color, and that is why it takes more resistance to break the fibers, and we are done. So 90 seconds, no, not even 90 seconds, maybe 60 seconds, and we are done. This is how a diode works. Now, These are the parameters. Whoever is using a diode laser, of course, I won't be discussing diode today, but this is how you have to take care. Make sure that your powers is controlled. You don't have to increase the power for your work. Speed has to be super slow. Emission mode, continuous versus pulse. You have to decide how many pulse modes and what settings and what pulse duration do you want. And the distance plays a role. And of course, the tissue is the most important. That what is the characteristic and composition of your tissue? Is it thick? Is it thin? Is it red? Is it pink? Does it has collagen? Is it chronic case? It's an acute case. And all of it together entails your treatment plan. Now, coming on to the topic of today, which is YZG2780 laser. How is it different from your conventional diode laser, which most of you would have seen in your on Facebook, social medias, or maybe some if you're some students are attending, you must have read about it. Now, these lasers are solid state lasers. What does that mean? Solid state laser means that you have an optical resonator like a box, which has a rod of yttrium, scandium, garnet, and on the top you have doping of erbium lasers. Now, these erbium ions are doped with 3 positive ions, and when the flash lamp puts on energy, flashes to this rod, they releases the photons, and they're high speed photons, and they collide with each other, and then you have two mirrors to amplify the process, and that what comes out is YZG lasers. Now, because the erbium has, it's an element which has an ability to have a higher number of electron orbitals and higher half-life, it can stay in a metastable state for a longer time. So this is a free running pulsed mode. You cannot have a continuous mode in a YSDG laser because it produces a peak energy of maybe 10,000 watts. You can't deliver 10,000 watts on the tissue. When you're using a diode, I'm using 1 watt for cutting. So I can't use 10,000, would be like a blast. So I need to decrease that 10,000 to something which can be used in the mouth. So what we do is that in these lasers, we have free running pulse mode, which means that your peak energy is high, but the distance, your pulse frequency, your distance between the two pulses is so short that 10,000 hits and goes, it hits and goes, and it doesn't has a penetrating thermal effect. Now that duration can be as short as 60 microseconds. It can be as short as 60 microseconds, which means 1,000 watt hitting for 60 microseconds would not have any pain, would not have any penetration, and would not affect your nerves. So you do your laser, you touch your erbium laser water lace on a tissue and tuck, and it goes into tuck and goes. So you don't have any depth of penetration happening, any damage happening, and that is why you can use these lasers to cut your enamel, dentine, your bone, and of course your soft tissue without any anesthetic, because huge powers but shorter duration. So this is called free running pulse mode. And what is the mechanism of action of all tissue laser? It's thermomechanical. In the diode, we said it's photothermal. Now it's thermomechanical. What does that mean? Now, this another difference between both the lasers is that this laser comprises of a laser which comes out from the handpiece, and then you have water and air coming in conjunction with the laser light. So, because this erbium laser, we discussed that it has a huge affinity towards the water that is coming out with the laser, this laser is absorbed by that water and energizes that water. This energized water hits the substrate. It could be a soft tissue, it could be a hard tissue, tooth, enamel, dentine, and vaporizes the matrix water, and thus the collagen matrix breaks and you start the ablation. So this is what is happening. It's called thermomechanical or cavitation process. And because of the thermomechanical action, these all tissue lasers are used in non-contact mode with most of the cases, especially when using the hard surfaces. I wouldn't never touch it. So when we did a study and tried to see the effect of a laser light on a substrate, we saw when the laser was too close to the substrate, there was a lot of heat buildup. The energy density was very high because the spot size was small. When we increased the distance, your spot size was bigger, your energy density was low, but it was insufficient to cut the tooth. So it was at 0.5 to 1 millimeter where you saw that it had a very optimum cutting. So when you keep this laser at 0.5 to 1 millimeter, the best effect of your air, water, and your 10,000 watt peak energy comes, and you're able to cut the surface. So to conclude, what is your YZG2780 running laser? It's a free running solid state, And because of its property of thermomechanical and free running pulse, you do not need local anesthesia 98% of the times. Because there is no depth of penetration, there is no vibrations, there is no microfractures, which happens when you use the drill. So when you're using a drill to prepare a cavity, there are so many microfractures that you see in the STEM studies, but you don't see it from the naked eyes, but you see it when you're using a laser. Very conservative preps. Why? Because when you use a drill, you take out a cavity en bloc with the tooth structure. But when you're using a laser, it evaporates all the bacteria because it extracts all the water from the bacteria and all the diseased tissue, which is nothing with the water. So what remains is a healthy tissue. So you don't have to struggle finding what the affected dentin infected, because it automatically selects. And then especially for your bonding procedures or endodontic, it removes the smear layers, open the channels, so you have better bonding and penetration of the sealers. And it of course is bactericidal like any other laser. And the best property is that it increases the acid resistance to your root surfaces, to your endodontic canals, or to cavity preparation, which means that your chances of having a secondary decay is less, because it leads to remineralization and sealing of the cavities. So these are all added benefits that you get with the erbium laser that you do not get with a diode laser. And let us see how it works. So this is an erbium laser. I'm using a sapphire tip. Sapphire tip is a glass strip. It does not have any hydroxyl ions attaching to it. So that means there's no interaction with water. And I'm using 1.5 watt, 75 hertz, 20-30% air and water. And you go very slow, and you can see no anesthetics, very superficial. I don't see any bleeding. The accessibility is good. And we are removing the frenum, and as I go deep, I can see the fibers. And the advantage of using erbium laser over a diode for a similar case of frenectomy is I can do a periosteal sporing with the erbium laser, which is not possible with the diode laser. Now, an additional work that you can do with the erbium laser, which you cannot do with the diode laser, is cavity preparations. You can remove your old composites and prepare the cavities with your water laser or your YCG laser. You can clean the implant surfaces, decorticate the bone, clean the extraction sockets, all this with your erbium laser. Why? Because number one, they have affinity towards hydroxyapatite. Number two, towards water. Number three, they can be used on the bone in non-contact mode and take out all the water and the diseased tissue. They can be used for flapless bone contouring procedures. When you have to do a crown lengthening, you don't have to raise the flap. You do the gingivectomy with the laser, take the tip inside, and just remove the bone as much as you want. And of course, it can be used for your acoustic streaming, cavitation process, and super fine irrigation and in the endodontic canals. And if you see the research and the studies, we know that the laser activated irrigation is actually superior to your ultrasonic irrigants. So this is how you can clean your chambers. But of course, I wouldn't be discussing your implants and endo. We would just stick to periodontal disease. When we talk about the all tissue lasers, I wouldn't go into the physics because this is the part of the course. And, 90 minutes is too less of a time for me to discuss all these parameters, which are super important when you're talking about your erbium lasers. So we have the power. You need to know about the powers. You have to be very slow. Why? Because it's a free running pulse mode. You need the laser time to interact with the tissue. It's not a blade where you just cut it. It's a laser. It's a biological equipment. It needs time to interact with the tissue. So you need to be slow so those packets of energy can react with the tissues. And then is important, of course, your tissue. What is the kind of tissue? What is the water content? What is the blood content? That is how you decide how much parameters, what energy you have to deliver. Then you have different tip sizes. You have sapphire tips, you have zirconia coated tips, you have special perio tips, special endo tips. So they obviously have a science behind and different protocol that needs to be followed. And air, water, why you definitely need air and water with the erbium laser, because your peak energy is 10,000 watts, 1,000 watts. So if you do not use water, it's going to burn. The system is going to burn. So you need to cool down the entire system. So you have a coaxial water and air to disperse the debris. And the most important thing, which the ones who are already practicing all tissue lasers must know, and the ones who are getting into it should also try to understand, is your pulses per second. Your repetition rate is something that defines the energy per pulse you are depositing in the area. Now, this is going to define your results, your regeneration. You cannot go above that, you cannot go beyond. So, if you have low number of pulses at a constant power, that would carry more energy. So, you have a deeper ablation. For example, you would do it if you have to cut an enamel because it has less water. But when I get into the dentine, I would lower down my density, energy density. Why? Because now the dentine has more number of water. And if I give a deeper ablation of a high energy, the patient would be sensitive. So I would go shift towards 50 hertz instead of 10 hertz. So this is what it happens when you have high number of pulses. You have a very fine cut but shallow cut, not a deeper ablation, rapid ablation but not deeper ablation. But when you have low number of pulses, which means very few number of pulses are carrying that extra amount of energy. So energy per pulse is going to be always high. So you will have a very wide, wide and very deep ablation. For example, if you want to cut the bone or you want to cut enamel, so I would use something like a 20 hertz instead of 75 hertz, which I would use in a soft tissue gingivectomy case. So this is what I use in my practice, 2780 and 940 nanometers. I would start with the clinical case discussions now. The roles of laser in periodontal implant infections be categorized into minor, major, advanced procedures. I would not be talking about implants and the basic protocols, but I would be just focusing on the role of laser in the periodontal disease management. Now, I have divided and classified it into non-surgical and surgical means. So either you can raise the flap and then use your erbium laser and the properties and the advantages to benefit your case, or you can go flapless and use your erbium laser to cause the LNAP laser assisted new attachment procedure or pocket disinfection, or you can follow a perio repair protocol, which is the for me, which is the most advanced and amazing technology which has changed the life of my patient, because this is a technique of doing a flapless, non-surgical management of the disease and gaining the bone without bone grafting, without local anesthetic, without raising the flaps. So this is the perio repair protocol, which we are going to be discussing as the first case. Now, this patient was referred to me because she was not able to chew food. She had a lot of pain in her gums and a lot of food lodgement because she had huge deep pockets, and she is a cancer survivor, and she was obviously on the anti-cancer therapy, so her white blood cells count was low, and she was very prone to infections, and she had got multiple flaps done, and she was 67. So I did not want her to go through another flap, so we just thought of going through the perio repair protocol. So if you see her gums, you can see the softness, edematous, the pockets, the structure of the papilla, they're all rounded. There's no stippling. It looks diseased. And that's the panoramic X-ray where we can see that she has some areas of horizontal bone loss, and the molars and premolars have some areas of angular bone loss. And the first step is your treatment planning. You always take the history of the patient. Now I know the patient is a cancer survivor, was on anti-cancer drugs, is immunocompromised. So that's important for me to evaluate in my mind the number of treatments or the number of laser sessions or some adjuncts needed. Second, you do the oral examination. Once you have done that, I would do a good phase 1 therapy, which comprises of scaling and root planing. You do that and you wait for at least 1 to 2 months and put the patient on maintenance. And when the patient comes back after 1 month, you reevaluate the remnant pockets, and those are the true pockets. And then you start your therapy and put the patient on maintenance, which is the mainstream of any periodontal treatment. So we see the patient has a pocket depth of 8 millimeter, and the tissue you can see around is very soft, edematous, bulbous, no stippling, no keratinization, not resistant to any forces, and giving her a lot of pain and discomfort. That's an X-ray of the same area with angular bone defect. And that's the other side for the record, that we have another deeper port probing depth of 7 millimeters, and she had a very typical 3-volt defect adjacent to the molar area. So we use the perio repair protocol for this, as stated by Dr. Rana Al-Falaki and Anton Scullion. So these are the steps. So what is a perio repair protocol? Perio repair protocol means you're using an erbium laser in a very minimal invasive non-surgical way. It's a flapless approach, where the first step is outer pocket depithelialization. So you have to settings on the screen if somebody wants to take a screenshot. You have to remove the outer pocket epithelium so that there is no apical migration of your oral epithelium. Then you take the laser tip inside the sulcus and you create a trough. create a trough till the level of the bone so you have space to clean. And then you take your mechanical instruments, which are very important in the therapy. You have to take your scalers and your curettes and fine tips, which can go inside, and you do the root planing. Once you have done that, you take your laser tip, radial firing perio tip to clean the inner socket, a wall, in a it's not socket, in a pocket wall, and you clean the diseased epithelium so your healthy connective tissue can attach back to the new knife cementum surface. And the different and the most important step, you change your tip, switch it to MZ6 or MZ5 tip, and you take it inside and decorticate the bone. So you decorticate the bone to release the growth factors and different healing factors from the bone, from the marrow spaces, that initiates a process of healing with the new attachment. And there's a bone fill that we see, and then again one round of circular debridement. There are no stitches involved, and you put some pressure with the cotton pack and for 2 minutes, and let the blood clot be stable. So this is what a perio repair protocol comprises of. Now, what is special about this protocol is the tips. You have radial firing perio tips like you see in the diagram. The tip does not have a donut shaped beam, aiming beam. It has a lateral. So there's a divergence of 40 degree, and there is just 10% of energy transmitting apically and 90% in all directions. So that means the moment you put the tip in the sulcus, which is not the case in the diodes, because the diode is an end cutting. It is not radial firing. Now this is radial firing. It's emitting energy in all the directions. So you are cleaning all the granulation tissue and the infected epithelium inside the pocket with this radial firing tip. And since only 10% is emitted at the apex, it makes sure that you are not injuring the base of the pocket, which is the most cautious area. Why? Because you have the attachment of junctional epithelium there. So this is what you do with the radial firing tip. Now let us quickly see how the interface or the machine looks like. So we have this interface where you have different options of restorative, perio, implants, endodontic disinfections, perio repair protocol. You just have it on the screen. You have to click it. Now I told you that this laser has a huge affinity towards water. So when we initiate the system, we do not want any water in the optical fiber. So we have to back off the water, which is called purging. We'll go into the settings and we'll switch on the laser, which is with 100% air. We take out the handpiece, and once we know that 100% is attained, we take out the barrel. Now this barrel consists of different kind of your tips. The tips are different in their properties, their lengths, their diameters. Depending upon the case, you have to choose. And there is a mechanism. So before you take the tip, you have to check the aiming beam. There should be no crack or fracture in the glass or the lens. And you can see when I increase the distance, the spot size is increasing. When I'm closer to the glove, then the spot size was less. And you take out the tip. That's a radial firing perio tip that I have chosen, 14 millimeter, 500 microns. And now I switch on 100% water and do firing just to check if I have the spray of water, because I cannot use this laser without coaxial air and water. Why? Like we said, because it produces a peak of 1000 watts. And if I allow those 1000 watts to come from the tip, every system is going to burn out. So we have to make sure that we have enough water to sustain that high peak of energy. Now we have a perio repair protocol. It comprises of 8 steps. You can see the first step, you have the settings. You can choose the tip. You have the power setting, which is 1.5 watt, 30 hertz. Like I said, when we want deeper ablation, you want less number of pulses. When you want a faster ablation, but not depth, then you need 75 hertz. And 30-40% of air and water you need. Then you have deepitalization zone. You do your scaling root planings. You do the bone decortication and circular debridement. We discussed about everything. And this is what we do. This is how you select and what's happening inside, or what we did. Let's see a video of the case. So when I was doing my radial firing perio tip inside the pocket wall, this is what is happening. You can see the animation that this radial firing perio tip is emitting radiations, the laser energy in all the directions, and it's cleaning this diseased epithelium and the granulation tissue. So that now you have baby connective tissue cells and new fibroblasts which can attach to the root surface. So it's like you have to clean the root surface, you have to clean the inner wall so that they both can stick to each other. You have the settings on the screen if somebody wants to know about what were the settings used. And this is what we attained after 3 months. So we kept on calling her we did the procedure She looked the same on 1 month, but I wanted to have a stronger follow up. So this is post op 3 months. And of the procedure, you can see the change in the soft tissue. How do you assess your results in a periodontal therapy? Number one, tactile. You take your fine straight probes and take it inside the pocket as much as it goes and start moving upwards. There shouldn't be any surface roughness or accretions. Then visually, you can see how the patient looks. Number three, wound healing. You can see how the tissues are healing, and there shouldn't be any probing depth, any cal, any suppuration or bleeding on probing. So we see that probing depths have drastically reduced. If I see the color contour consistency of the soft tissue, you can see the papillae settle down now. The tissues are firm, resilient. They look very healthy. And what was very promising and surprising and very exciting was the bone fill. Now you can see the 3 wall defect. So we did not raise any flap. We did not do any kind of bone grafting, but we were able to increase the bone density in the tooth. So I did not enter the flap, opened it and enter. I don't know if that's 3D fill, but definitely I see there's some fill and there's good quality of bone, and that's good enough for me to retain this teeth. So you have a bone fill there, and you see the other side. You can see the drastic difference in the soft tissue. Your gums were bulbous, soft, edematous, so big in size, and now they're settled, firm, resilient. You have the stippling, you have the color back, reduced probing depths, and again you have the gain in the bone level. So this is the most, this is what we talk about when we talk about minimal invasive laser dentistry. When we talk about recent advances, we talk about these procedures where the patient actually do not need local anesthetic. So I give the local anesthetic because I'm more comfortable with the anesthesia. But with this technique, you usually don't need the anesthetic, and you can just go ahead without the anesthetic. And it's a single sitting, so you don't have to call the patient for every quadrant. Single sitting, one sitting, and you are able to settle down the tissues, gain the bone, and take care of the bleeding, suppurations. And it's a very minimal invasive way of restoring the periodontal tissues. So I have documented and published this case. If somebody wants to understand the step-by-step procedure and photographs, I would be happy to email it to you. Another patient, this patient had a lot of medical history. So he was diabetic, uncontrolled diabetes, and then he had metabolic syndrome, which comprises of obesity and high cholesterols and hypertension. So the patient was asked to go back to the physician and asked to control all his medical parameters before we started. And this patient had a history of flaps. So he had a flap surgery twice, and he was not happy. And he was actually referred to us for implants. And I don't know how many of you would decline that offer and would say, no, we are going to save this tooth, because when we see these patients, we all of us think about, okay, this is all in 4 cases or socket shield and all those things, and bone grafting, all those things come to our mind. But very few of us, or probably, none, think that, okay, we can save all of them. And the first attempt should be about the saving, because the implants were not invented to replace the natural tooth. They were invented to replace your missing sides, to help the patient, missing teeth, to help the patients to eat their food. So we should be very minimal invasive and offer the treatments that we would do it on own cells rather than being very aggressive and invasive. So the patients had definitely a compromised soft tissue, and you can see the probing depth was 67 millimeters. So the first step, like I said, always take the medical history, scaling, root planning, wait for 1 month, reevaluate, and then start your therapies. So we did the same peri-repair protocol that comprises of outer pocket depithelialization. There's an option of pseudo pocket. If the patient has pseudo pocket, you can do a gingivectomy. If not, then I wouldn't suggest you to cause a recession at the site. So, and then you can take your laser and create a trough inside the circular area pocket A to have an access to the pocket, and you remove the inner wall of the diseased epithelium. And once you have done that, I would change my laser to MZ6 tip and do decortication of the bone, then come back to the brittle filing periodip and do the debridement of the wall. So in between, a very important step that you always have to remember is your scaling and root planing. So using a laser doesn't mean that this would suffice the mechanical therapy, because the hard accretions have to be taken out with your scalers, with your curettes, and that's a very important step in aiming to gain the bone. So you can see the soft tissue change. This is post-op 3 months, and you can see the drastic difference in the quality of the tissues. I know this patient for last 6 years. He's been maintaining well. I haven't done even single extraction for him. And imagine a scenario when the patient had come for a full mouth implants and we send him back saying no, that we can just restore the teeth. So you have to take care of the medical history, because I understood the fact that the patient has a history of recurrence, has a refractory cases, because he already had a flap, he's low on hygiene, he's systemically compromised. So we have to take care of all the parameters, not just lasers to control the disease. And once you take care of all the parameters, this is what you get at the end. So if I see and take a closer look, you can see you have the if I see the swelling and the bulge around the canine is settled down after a few weeks, and this is what you get after 6 months. Your color, contour, consistency, your pigmentation, stippling, everything's restored. The tooth looks very healthy. I have reduced probing depths on both the sides, all four quadrants. You can see the probing depth is reduced from 8 millimeters to 2 millimeters. And most of the, if I see the IOPRs and compare, I see a lot of bone gain, and I see the increase in bone density, if not bone fill. So the quality of the bone is good, and now it's not infected. So that means we are not holding on to the infected bone that might be a problem for future implants. So this is now like a naive, healthy, clean bone, and you can compare the panoramic x-rays. So I did not put a lot of IOPRs here, but I could see that all the vertical angles had become horizontal, and we had some sort of bone fill almost at all the areas. I was fortunate to publish this case as well. If somebody wants to read, please email me. Now, my studies and my cases go in conjunction with these articles with Dr. Rana Al-Falaki. She's done extensive study on the peri repair protocol, and what she concluded was that average probing depth reduction from this peri repair protocol is from 8.8 to 2 millimeters, which is significant. And at least minimum, if you compare the studies, minimum every case would have at least 40% of bone gain. So imagine a situation where you don't have to raise the flap, no local anesthetic, you don't have to do a bone grafting or increase the cost of the patients, and you are able to gain the bone. So this was a use of an erbium laser in a non-surgical fashion. You can also use the erbium laser for resistant sites who are not responding to a non-surgical with the open flap manner, where this portion you can see that the patient had a lot of inflammation and suppuration and bleeding and probing and not maintaining well. This is the X-ray. The patient does have some verticular defects. So we open the flap, we do the scaling, root planing, inner wall depithelialization with the laser, and use the laser like as postulated by Dr. Farquhar, where he talks about that if you use the erbium laser on the root, so number one, it's more selective than your hand instruments because you over instrument, and that leads to sensitivity, which doesn't happen in erbium lasers. And also it creates a spindle shaped fibroblasts which are more ready for the attachment to the cementum. So this is the new flap after your cleaning. We have done the inner flap depithelialization. It's an old case, so I've used silk sutures. I don't use them any more often. We do the outer pocket depithelialization, which is very important, significant step. And you can see the pre and post. There's a significant difference on how the patient feels. So the question, if would I have got these results if there was no laser? I don't know, because I always use lasers as an adjunct at some or the other point, because they do have a benefit over my conventional therapy. And I do not want to leave any microorganisms or biofilms attaching to the root surface, because that's going to hamper my healing process. Another article by me published. If anybody wants to read, please get in touch with me. I'll be happy to email you. Another open flap case you can use. You have this patient was referred to me for addressing premolar. The premolar was grade 1 to 2 mobile. We checked the probing depth, and we saw the patient had an angular defect, looks like a 2-wall defect, and a 9 millimeter probing depth. So now we wanted to open the flap. Why? Because the reason of opening flap is number one, access, number two, regeneration. If you're not doing any of the two, I don't see any reason of opening a flap. And we used a laser to open a laser flap. So we did not use any blades. I used the laser to do chopping and open the flap. So no use of blades. And this is how the defect looks. And this is obviously after cleaning, we use the laser as postulated by Dr. Rana Al-Falaki and Dr. Anton Skullion. where we talk about the use of water lace to clean the defects because it absorbs all the water from the granulation tissue, which otherwise is very difficult if you do it mechanically with the bone curates. So you can do it just right with the laser. Once you have done that, you remove the smear layer which is formed with your mechanical instruments, and now you do the bone grafting to fill that defect and use a mucograft to support the soft tissue, and you end up suturing it. And you can see the results that from your 9 millimeter, the probing depth reduced to actually 2 millimeter, and there was a significant bone fill that I could see. So yes, it's very promising, and it takes care of the residual biofilms or those inflammatory markers that was or those pathogens which were inside the tissues, because that you cannot take care with your mechanical therapy. Another publication, similar case, it's got step by step explanation if somebody wants to read. Now, these were the cases where I showed you the role of erbium lasers in soft tissue management and bone gain. Now, you might just use it for LNAP process like laser assisted new attachment processes, and just use it for a regular pocket therapy where you're not aiming for bone gains but just reduction of pockets and restoring the periodontium. So this patient was referred to me for removal of pigments, and I have a habit of checking the probing depths, irrespective whatever the patient is referred to me for. And I saw when I probed her, she had a lot of bleeding and she had pocket depth of at least 5 millimeters. So the probe that I'm using on the screen is UNC 15, University of North Carolina. It has the color markings of 5, 10, and 15 millimeters. So it's a very accurate probe, more accurate than your William probe. And you can see bleeding, and we all know that bleeding means it's an active indicator of the disease. There's active inflammation going on, and we need to address it other than your removal of the pigmentation. So this is what we do. We use your erbium lasers. We take it inside the pocket depth. So I'm not doing a perio repair protocol. I'm just simply disinfecting the pocket, following it, and after that, I would be doing outer pocket depithelialization. So you go slow. This is an RFPG tip, 14 millimeters, 1.5 watts, 30 hertz, 30 and 40% air and water respectively. And once you have done that, you clean all the pockets areas. So you can see it's very site specific. I don't have to, I'm only cleaning the areas which has pockets. If an area around the tooth does not have a pocket, I wouldn't enter and injure it. So what are we doing inside histologically? First, we do the probing. Then the diseased epithelium is the inner lining. So we take the laser and clean that inner wall. Once that inner wall, diseased infected epithelium is removed, we take a curate or a sonic scaler and clean the root surface. So now your epithelium is clean, your tooth is clean. Then one more round to cause the cauterization so there's no bleeding. And now you do some pressure pack so that the clot is stabilized and new attachment can start happening. So this was documented by Dr. Mark Nevins and David Kim, this procedure of using erbium lasers for the NAP procedure. And then we went ahead and did the depigmentation with the same. You can do it with a 940 nanometer also. Invariably, I use a photobiomodulation, the contour handpiece, for a faster healing and minimal pain post-op. So this goes without saying, any surgery, root coverage, graftings, implants, every case has to end up with my photobiomodulation because it has a significant role in faster healing and minimal post-op complications. So this is how the patient looks like immediately post-op. After the periodontal therapy and depigmentation, and this is how the patient heals. You can see the pigmentation is removed, and let us see if the gums have improved. Yes, the gums have improved because I do not see any bleeding on probing. This is post-op 3 months. The probing depths have reduced from 5 millimeters to 2 millimeters, and we see the same. And now I see the consistency of gums is much better, and they're not loose and fragile like they were pre-op. Another similar case like a pregnancy gingivitis. Now, this we know that there are so many patients who come to our office during the pregnancy and the gums are bleeding, or they have the lower incisor which is moving or which is mobile. So this is a very common problem, and this happens why? Because during pregnancy your progesterone estrogen increases and your periodontitis causing pigmented bacteria, Prevotella intermedia, is higher during periodontal diseases. So this bacteria feeds on progesterone, so the quantity of this bacteria increases, and there's more exaggerated inflammation and attachment loss. So often this is neglected, and the patient's gingivitis, pregnancy gingivitis, becomes periodontitis. So this needs to stop. And even if you are doing the scalings and the patient is not responding to your phase one therapy, then there needs to be done something additive, which can be a laser, since it is safe in pregnancy. And this is how the patient looked like after scaling and replanning. We waited, asked her to come back after 3 weeks. She still had persistent pockets and bleeding on probing. So we did the scaling and replanning for her with the laser, and this is how she looked. You can see there's a remarkable difference in how she looked before and after. The color is come back. There's no the red margins, inflamed margins are not there. She's maintaining well. The stains that I see on the post-op picture is because of the chlorhexidine. She was overusing it, and you can see there's a reduction of probing depth and the papilla. Just take a closer look at the size and the shape of the papilla. It looks so